Dr. McBain. Good morning, everybody. Thank you very much for listening to the next 20 minutes. So, as Dr. McBain said, my presentation this morning is about toxicities relating to radiotherapy treatment, specifically SRS and the whole brain radiotherapy. So first of all, just to clarify that toxicity is just another word for side effect of treatment. We use them interchangeably when we're talking about side effects. So how does toxicities or side effects actually occur from radiotherapy? Well, radiation actually damages the DNA within all of the cells into which it comes into contact. So all of the cells within the treated area, which is primarily the brain metastases, but also a small margin of normal tissue around it as well, will be affected by the radiation. And the radiation works in one of two ways. It can either cause a single stranded break within the DNA, as indicated in the top picture, or it can cause a double-stranded breakage, as indicated in the bottom picture. The difference between normal cells and cancer cells are that the normal cells are able to identify that the DNA has been broken and they are able to repair the damage that has been caused. However, the cancer cells don't have the molecular mechanisms that are required to do this, and therefore they are unable to repair the damage and therefore they die, or the cell death occurs. We get side effects because of the damage to these cells, and that's why, for example, we get alopecia is because the hair follicles are affected by the radiotherapy, and so the hair then falls out, hence the alopecia. If, for example, when we're treating other areas of the body, we treat bowel cancer, we can get diarrhea or loose stools as a result of the cells within the bowels being affected. So radiotherapy, just to clarify, is very specific to the area that you treat. So you only get side effects relative to that area. So when we're treating the brain, we only get side effects relative to the brain. So hair loss on the head will occur, but you won't lose eyelashes or eyebrows or hair anywhere else on the body. The main factors that affect side effects are the volume or the amount of brain that's being treated, the amount of radiation dose that is received by that tissue, and in technical terms, the amount of radiation we use is called a grey. So if in the feedback letters and things you see these letters indicated, that is the amount of radiation that they received, and how over what time period the treatment was given. So we call it a course of treatment. So that can be 5 days, 10 days, or 3 days or 5 days. Any combination of these relates to the schedule of the course. And again, a technical term, but we use a treatment. The technical name for that is called a fraction, or we use this hashtag sign to indicate that as well. So if you see that in end of treatment letters, that's what that is referring to. So just to recap on Dr. Whitfield's, I do this because it's relevant to the actual side effects that patients get. So there's the two types, as you now know. So there's whole brain radiotherapy. It's a course of treatments, normally 5 or 10 treatments. It's a lower dose, but a larger volume. The stereotactic radiosurgery is 1 or up to 5 treatments with a much higher dose but a much, much smaller volume. This just indicates the area of treatment, so get the right button. Whole brain is this whole area within the purple square, so that whole area receives treatment. It's delivered from 2 sides, the right and the left. And stereotactic, as you now know, is a very conformal area specific to where the metastases is. So over what timescale do toxicities arise? Well, we know from practice, and the literature also identifies, that the toxicities occur over 3 different time points. There's the acute phase, which happens whilst patients are actually on treatment and for up to 6 weeks afterwards. There's the early delayed, which occur up to 6 months after treatment's been given. And then there's late side effects, which occur any time from 6 months, any time period after that onwards. It's quite important to realise or to take on board that acute and early delayed side effects are in the main part reversible, so they are transient side effects that happen. So, for example, patients experience alopecia during treatment, but the hair will regrow back. It just takes about 3 to 4 months for it to do so. Late side effects, unfortunately, if these arise in patients, are generally non-reversible. They are a permanent side effect, and it's more a case of lifestyle change or managing that appropriately. The development of acute toxicity does not predict or indicate that patients will go on to develop the late toxicity. It all relates to the dose of radiation that's been given and the volume that's received the treatment. So what are these acute toxicities that we talk about? Fatigue is experienced by every patient that undergoes radiotherapy. Patients that have it to the brain tend to experience more fatigue than other areas. So, for example, somebody having their limb treated doesn't get as tired as somebody who has their brain treated. Cerebral edema is something that we see quite commonly, and it's been shown to you already this morning, but this is the brain metastases here, and the black area surrounding it is the edema. This can present symptoms such as headaches, nausea, vomiting, confusion, everything that we've heard already this morning. And this combination can also be known as raised intracranial pressure when you get the mass effect. Alopecia is very common. It's experienced by everybody that has radiation to the brain. If you're having whole brain radiotherapy, you will lose, or the patients will lose, alopecia from the whole of their head. For patients that undergo SRS treatment, it's patchy hair loss related to where the beams actually go in. Erythema is the changes to the skin that develop. It tends to be a mild pinkening of the skin, a bit like a mild sunburn reaction. Sometimes patients tend to get it worse behind their pinners, and it's just a case of seeing that develop. That tends to happen towards the end of the treatment rather than at the beginning. As well as these acute ones which I've listed, you can also get worsening of any symptoms that patients have got, and we quite commonly, when we're consenting them, make them aware that things can get worse before they get better, and that's even during the time period that they're actually on treatment for. Early delayed toxicities, so these are the ones that happen for the up to 6 months after the treatment. We see this reoccurrence or the worsening of symptoms that patients have. Somnolence syndrome. Can be quite distressing for patients sometimes. They're very, very lethargic. They've got very disinterested, not really wanting to do very much at all. Treatment-related inflammatory changes, sometimes previously known as pseudo-progression, is quite well illustrated on the images below. So if we look at image A, so this is a brain metastases before any radiotherapy was given. Image B isn't, these are all MR scans, sorry. Image B is of the brain metastases 3 months after the treatment. So you can see, if you were to look at this scan independent of other scans, you might think that the brain metastases has actually grown significantly and the treatment has been rather useless. However, 3 months later, so this is now 6 months after the end of treatment, you can see that the brain metastases has actually shrunk in size quite considerably. So it's important to take these scans in context of how the patient is in themselves and also about the treatment and making sure you give the treatment time to work. In terms of late toxicities, we do consent and talk to patients about the neurocognitive effects, particularly the short-term memory, so the new information that's provided to them, retaining new information, remembering people's names and what they wanted from the shops and things like that, it can be quite difficult for them. Radiation necrosis, something that we've touched on just before, this is quite, we're seeing it increasingly with SRS treatments actually, and it's believed to be because of occlusion to the blood vessels, which restricts obviously the blood and the oxygen and the nutrients to the tissue, and therefore the tissue starts to die and become necrotic. Endocrinopathy, so the pituitary and hypothalamus can become underactive and so stop producing the hormones that are necessary for the body to function. If we're treating more frontal lesions, there is a risk of developing cataracts or dry eye from the treatment. Permanent alopecia or hair thinning, particularly more for superficial lesions, so lesions that are closer to the skull of the surface where the dose is going to be higher to the skin and therefore the risk of the hair follicles being permanently damaged is increased. And cerebrovascular effects, again this is due to the effect on the blood vessels, but there is an increased risk of developing stroke and hemorrhage because of the radiotherapy. In terms of managing the toxicities, it's quite important to remember that toxicities are very patient-specific, so you can have 2 patients that have the same treatment but are having quite different toxicities. It also relates precisely to where the radiotherapy was given, so people who have lesions in different areas will have different toxicities. It's quite important that we reassure patients of expected side effects, that they are exactly that, they are expected, and this is a transient thing that will settle. But as much as it's important to give them the medications to manage side effects, it's also important to make sure that we have the right level of care and support and the right people involved with managing them as well, so ensuring that the physios, the OTs, the community teams are all involved when appropriate. For acute reactions, just some general advice that we give out. In terms of fatigue, making sure patients are eating well, they're hydrated, and also, acknowledging that they've had treatment, and so taking some time out to recover from the treatment is just as important as any medications that you can take. So making sure they take it easy, take rest when they need to, have a sleep in the afternoon if they need to is absolutely fine. For edema or for some of the symptoms, so for example, if patients have mild headaches, paracetamol is absolutely fine to give. If patients are feeling nauseous, antiemetics are fine. However, if we're getting more the raised intracranial pressure, then steroids will be the way forward. In terms of managing skin reaction, we recommend that moisturisers are used. New guidelines from the Society of Radiographers actually have demonstrated that there is no preferred creams to use for radiation reactions. It's just whatever the patient is comfortable to use. However, what we do say is try not to get SLS-based products. And that's because this is a chemical that's added to make products such as shampoo and conditioner smell nice and make things nice and soft and shiny. But actually, if they're left on the skin, they can actually dry the skin out. So what we want to do is add moisture to the skin. For alopecia, unfortunately, there isn't anything that we can give the patient that is going to make the hair grow back any quicker. It's just a case of offering them supportive devices such as wig referrals or headscarves. For this middle, early, delayed side effects, it very much depends on what the patient's actually presenting with. If they're starting to have an increase in their seizures, then it would be appropriate to consider increasing their antiepileptics. Or likewise, they might need to go up on their steroids for a short while, or if they're not on any, then to start a course of steroids. For late toxicities, we use a combination of medicines and treatments. So, for example, steroids, you're probably beginning to get the feeling that steroids are used quite commonly, and they really are for a reason, as Liz will go on to. But steroids can be used to help with the symptoms of radiation necrosis, for example. Cataract replacements if patients develop cataracts, it's a simple day case operation to remove the cataract, so they can undergo that. Hormone replacements, if necessary, it's just tablets to replace any hormones that are no longer being produced. In terms of the neurocognitive effects, it's quite often practical changes, so making sure patients are accompanied by somebody to consultations or to new appointments and giving them the opportunity to write things down. We've even had some patients come in with voice recorders to record our consultations so that they can try and remember exactly what was said. So, in summary, radiotherapy damages all DNA within the target volume. However, the normal cells have the ability to recognise this damage and repair the damage. The cancer cells don't have this mechanism, and therefore cell death occurs. The toxicities arise because of the damages to the cells. There's 3 stages of toxicity. There's the acute, so on treatment and for 6 weeks afterwards. Early delayed, which is up to 6 months after treatment. And then late, which is anything from 6 months onwards. The treatment side effects differ from patient to patient and depending on what type of treatment you have. And then toxicity management is managing them in terms of support, making sure they've got the right people in or around them, and also changing medications, adding new medications in and when necessary. That's it. Thank you very much.